Welcome to Life in Sirens, Behind and on the Scene, a podcast by first responders. We're your hosts, Sophie,
Jamie,
and Aubrey.
The content provided in this podcast is for informational and educational purposes only and should not be considered medical advice. The views and opinions expressed by the hosts and guests are their own and do not necessarily reflect the official policies or positions of any medical institutions, emergency medical services, or healthcare organizations. Patient privacy is a top priority, and all discussions involving real-world emergency situations are de-identified and altered to ensure confidentiality. Always consult with a qualified healthcare professional or your local EMS protocols before making any decisions regarding patient care or medical practices. Listener discretion is advised, as some topics may include discussions of real-world emergency situations.
Pediatric sepsis is one of the most dangerous look fine calls we run because kids compensate until they suddenly can't.
And in the U.S., this isn't rare. National pediatric sources estimate 72,000 plus children are hospitalized for sepsis each year, and about 7,000 children die, often described as more deaths than pediatric cancer.
So today, we're doing this from an EMS lens. What sepsis looks like in real homes, real nursing facilities, real urgent cares, and how Handtevy style thinking, weight-based, pattern-based, and reassessment heavy helps you catch it before the crash.
And by the way, this isn't sponsored. This is just something we found to be really useful, and we wanted to share it with you guys. So one thing that Handtevy does pretty well is hits hard on sepsis. So our first section, we'll just talk about what the heck is pediatric sepsis and what isn't, which, just like any human, any adult, it is sepsis. It's not just a bad infection, right? It's actually an infection that leads to a dysregulated response that causes organ dysfunction, and when it progresses to septic shock, obviously perfusion will fail. And in kids, hypotension is a very late sign. So if you wait for low blood pressure, you are way behind the game. And like Aubrey said, 72,000 plus hospitalizations a year and around 7,000 deaths. That is unacceptable, and we could absolutely be doing more in the field for adult and pediatric sepsis. So what does it look like?
So a big hinge on Handtevy style EMS framing is that we're hunting for patterns, not one specific vital sign. And so what's one of the first things that we see in kids that is like, oh, we're sick?
For sure,
Fever.
Right? So if you're going to have an infection that is worsening and progressing, you're going to end up with a fever. Tachycardia out of proportion.
I think we should really dive into that one.
Yeah. So what does tachycardia look like in kids? Like, what's the reason a kid would be tachycardic?
Screaming, crying.
Yeah.
Right? There's a lot of reasons. Like, it depends on if you're looking at an infant or like a 9-year-old. There's huge ranges in the pediatric population of what tachycardia actually is numbers-wise. And then if we're talking about out of proportion is the most important phrase when you're talking about tachycardia, because a pissed off kid is going to be tachycardic. Yeah. But you have to really weigh that with what their normal should be and if it's appropriate with their current behavior.
100%. Altered mental status, and we call this, the mom says the kid is not acting right. I think we hear that a lot. They're just not acting right. Something's wrong. I know something's wrong. Mm-hmm. Trust them.
Yes, if mom says they're not acting like themselves, that's altered mental status until proven otherwise.
Yeah.
And it's hard in our brains, I think, at least for my brain, to be like, that child is altered. Like, that's weird to say.
Because to me, that's an adult
problem.
Like assessment.
Because all kids are just weird.
Yeah, kids are just
I'm like, you don't know who the president is, you little weirdo.
How do I figure this out? Yeah, they are. They're just little weirdos, and they're all at different stages of development. Mm-hmm. So a 2-year-old may be able to talk to you in full and complete sentences and know their own schedule.
The variables are insane.
Right. Or they may like barely know how to say their own name.
Yeah.
Like, it is such a vast difference of like appropriate milestones for kids that it's hard to know what it looks like. So defer to mom,
their parent.
Parental figure.
Yeah, their parent will be able to tell you that something is not quite right, and I would just run with that.
Yeah, whoever spends the most time with that kid is who needs to answer that question. I don't care if it's nanny, grandma, whoever.
Yeah.
Another thing in kids, like the easiest way to differentiate perfusion changes with cap refill, which
Yeah.
you can do on any patient, but is especially pertinent in pediatrics. So any delayed cap refill, modeling, cool extremities, anything like that will be a red flag.
And modeling is huge. Kids that are in any kind of distress, whether it's perfusion-based or respiratory-based,
They get modeled.
and they get modeled quickly.
It's very alarming.
And their core will even
Yeah.
get modeled. Like that's not something you see very often in adults, but you
Yeah.
will see it with sick kids.
Yeah.
A respiratory distress without a clean explanation. And when we talk about that, we just mean like they don't have an upper respiratory infection. Why are they breathing like that?
Yes.
What
like,
is going on?
This is not RSV or
Yeah,
the flu.
or pneumonia or whatever.
Absolutely.
Or maybe it is, but that is also a red flag
Also
with
a-
those other things.
Also a red flag.
Now let's talk about why EMS misses this. Most pediatric sepsis starts as something we see every day. Viral symptoms, GI illness, ear infections, pneumonia, UTI. The trap is that the beginning looks ordinary until the perfusion starts failing. So let's talk about a kid who is already diagnosed with the flu and was okay, but suddenly is not.
So you've got your parents report to you. They call 911. The parents report that he's had a high fever for 2 days. Now he's sleepy and won't drink. What are your red flags that a lot of time EMS underestimates?
Any lethargy in a child should be
Yeah.
an automatic red flag.
Especially when there's a lot of people around.
Yeah, especially with strangers. Yeah.
Yeah. Anytime that the child is not able to have good intake, because nothing is going to get mo better, and things are certainly going to get worse if they have no intake.
Crying without tears,
Mm-hmm.
decreased wet diapers. Obviously, those skin changes.
Right.
Yeah.
And this also, it hinges on age as well. Because if you have a 3-month-old with these symptoms, with no intake,
Mm-hmm.
you are like, that is a sick kid.
Yeah.
They have
Mhm.
no immune defense. Like, we are in a bad way. If you have a 3-year-old that has had a fever for 2 days, is getting lethargic, and hasn't drank much, your window's a bit longer. So their intake is not nearly as, like, the lack of intake is not
Yeah.
nearly as severe
It's
as
like us
as you
when
get
we're sick.
older.
You
Oh,
have
I didn't eat
more-
today.
Yeah, compensatory
You have some
mechanisms.
reserves.
Yeah.
Right. Still not great for a 3-year-old, but it is more manageable as far as just intake goes.
Yeah.
So why does it matter?
Well, so any sort of viral illness can be complicated by any bacterial infection, dehydration, inflammatory spirals. The flip that we see in these patients, so where we start to be very concerned, is when there is a perfusion issue.
So, did that patient have sepsis?
Oh,
I
yeah.
think high suspicion, right? High suspicion for sepsis.
Yep.
Yeah, definitely until proven otherwise.
And, like, we do need to do some more investigation. Like, has this high fever gone on for 2 days without medication? Like, stuff like
Mhm.
that. Like, how have we been managing at home?
Yep. Is it responding to maybe Tylenol
Right.
and then we're rebounding right back? Or is there no response to Tylenol, or at least not a significant one?
Yeah.
And like, how long have we been ill?
Right.
And has it improved at all? Because like, kids can rebound decently quickly from illnesses. And so your 2 days high fever, was he like kind of not feeling great for days before
Had
that?
some kind of.
And this is just when we've gotten like sick.
Mhm.
Getting a timeline for the illness is super important, because if it is like, this came on this morning, we just noticed it, he just spiked a fever, he has not been complaining of being sick, it's only been 4 hours.
And some kids, like, remain snotty.
Mhm.
And they remain mildly congested all winter, right?
Mhm. They're just gooey.
So maybe they have been, this has been going on all winter, so we didn't even take them to the doctor. And then the last 2 days, though, they had a high fever. So maybe now that respiratory and viral
Mhm.
situation has turned into pneumonia or something.
Right. And like, snotty all winter, kids are kids. They're like not just great at controlling
No.
secretions
Oh,
in
gosh,
general.
no. They can't cough very well.
Yeah, so
Can't blow their nose.
yeah, chance of like a huge mucus buildup or like pneumonia is much higher.
You know what's really funny? Whenever I worked at Peds, sometimes, depending on what the situation was, they would have occupational therapy come and they would teach kids how to cough and blow their nose.
Oh,
It's really cute.
That is
Yeah.
really cute.
That's adorable.
Yeah.
All right, so another situation is the just dehydrated toddler.
Okay, please don't stop saying this. I hear this all the time from providers. They're just dehydrated, or they just have a fever. This is how they're supposed to act. How do you know them?
Also, dehydrated kids is not good.
No.
Because guess what? They're tiny.
Yes.
And so if they get dehydrated, their perfusion gets affected really quickly.
And also, if a kid is turning down because at this point, you know, parents are probably like, they've tried everything. They've tried the Pedialyte. They're like, here's freaking orange juice. Here's apple
Here's a
juice.
Capri
Here's
Sun.
a chocolate milk.
Yeah.
Like,
do you want a Diet Coke?
and
Like,
toddlers,
they don't care.
they just be like guzzling down juices. Okay?
Oh my gosh.
So if they're not drinking, something's wrong.
Yeah. And if you have a GI illness, so we've had nausea, vomiting, diarrhea, decreased oral intake, and tachycardia.
I think this gets so slept on.
Right, it does.
The GI illness.
Those are all problems. Like a GI illness with decreased oral intake, tachycardia, they've had vomiting, they've had diarrhea. That kid's volume down.
Yeah.
And
yeah.
Things are coming out, nothing's going in.
Absolutely. Instead, kids stay at home and die with just a GI bug.
Yeah, because a grown-up is allowed to be just dehydrated.
Mm-hmm. Because we have plenty of reserves.
And we have willpower. Be like, okay, I just have to drink this Gatorade.
Yes.
All right? Like,
the chance of us just withering away secondary to dehydration is slim, but kids, they don't know.
yeah.
And they haven't learned
just, I don't feel
those
good.
bodily triggers yet. And the parent is supposed to be the one that like drives that. But guess what? Sometimes a lot of parents don't know. They're
Yeah.
like, they're just dehydrated. But then they get super volume down and end up with just trash perfusion.
Weakness and... Yeah.
So you start with dehydration. That's like kind of what you've been called for. And then you find delayed cap refill, cool extremities, and they're just not acting right.
Yeah. And it's okay to give kids fluids, guys.
Mm-hmm.
We all know that fluid resuscitation is important in dehydration, obviously. Also, in sepsis, it doesn't matter that they're not a grown-up.
Mm-hmm.
They need aggressive fluid resuscitation.
Yeah, honestly, even more so.
Definitely. I know, too, a lot of people will be like, I don't want to start a line on this kid. I don't want to start a line on him.
Do it.
Just, if it crosses your mind that I think this child needs an IV, because if that crosses your mind, that means they do. Because most of the time you're going to err on the side of no.
Yeah.
Yes, because you don't want to just
Stab
traumatize this
children.
kid for no reason.
Yeah.
Yeah,
Right.
for sure.
So, how do we administer fluids with this kid?
20 mLs per kg.
Yeah.
Yeah.
And if you want to err on the side of like being really conservative, depending on if you think this is just dehydration.
Yeah.
Or if you think you're septic, sepsis should be your 20 mLs per kg. If you feel like you're just ill, 10 mLs per kg is fine.
Yeah.
Yeah.
If they're teensy small, use a flush, man.
That's,
Use flushes. Like
literally.
increments of 10. You give a flush, hang out for a little while, give another one. Like
Yeah.
that works great for little babes.
Mm-hmm.
And then as they get older, use your 100 ml bags, use your 500 ml bags. Like, don't give yourself the opportunity to over volume resuscitate these kids.
Right.
Use your Buretrol.
Yeah. Or your-
Honestly, like a Buretrol. If you don't have a
Mhm.
pump, use a Buretrol.
Yeah. And if you do have a pump, use a pump. So what kind of mental model do we want to have with these kids when we're trying to figure out fluid dosing and med dosing? Like, what do we want to be thinking about early on in the call?
How much does this baby weigh?
Right? Weight. Especially if you have a little nugget. Kids go
Yeah.
to checkups all the time.
They
I
really
bet you
do.
mom will have a weight for you like within a pound range.
Mm-hmm.
It will be within the last like 2 weeks, 3 weeks, month.
Yeah.
Which is great. Even like toddlers. Parents be knowing how much those kids weigh.
Yeah, mom for sure.
Yeah. Absolutely. Dad, maybe not.
Yeah. Yeah, so it's not just about how old they are, right? Sometimes it comes down to their length. That's usually how we do adults,
Yep.
right? What is their ideal body weight? Because
Yep.
it's not always about how much or
They-
how old they are, how much they should weigh,
For sure.
right?
And then reassessment is super important after each intervention. So if you have a little nug and you're doing like 20 mLs per kg, let's say they're only 3 kgs, so you are going to just 60 mLs, right? And you want to do that in flushes because we want to do this like over an extended period of time. After every flush that you push on this little kiddo, like reassess.
Also, remember that if you are pushing a flush on a teeny tiny baby, that their vasculature is really small, and you shouldn't just be pushing a whole flush like you would push it on it. I don't know if that's...
Yeah, slow
I know you'll
roll.
probably know that, so you're probably like, Sophie, hush. But if you don't,
Slow roll it.
we don't want to bust all their blood vessels.
So when you do reassess, what are you going to reassess for?
Well, this one we talked about before that we feel like doesn't exist in kids. Absolutely does. Mental status.
Yep.
Sleepy. Lethargy. They are difficult to arouse. That's the scariest freaking kid.
Mm-hmm. If
That's
they're
the
hard to...
scariest kid. I've had one recently, and I'm just like, stop!
Wake up!
Wake up! Stop doing this to
Right.
me! You're stressing me out.
Yes, or are they perking up? Are they starting to
Yeah.
track you with their eyes?
And
Are they
even if
starting to
it's-
realize that you're not their mom?
Right. I was gonna say, and even if they're not interactive with you, are they interactive with family?
Mm-hmm.
You know, that weak cry. You know, when you hear it, you're like, oh, that's a sick cry.
That's a sick kid.
It's like,
Mhm.
you know what I'm talking about?
It is. It is.
It's so sad.
You're like, oh my gosh. Is their work of breathing improving, or is it worsening?
Yeah.
And lung sounds. Keep listening to them baby lung sounds.
Yeah.
See how we're doing.
Don't forget about that.
Yeah, especially if you're concerned with something like sepsis. Like, you want to make sure everything's staying where it's supposed
Yeah.
to.
You don't need to panic because the system is the same, right? As far as like how we approach assessment,
Mm-hmm.
right? Use your pediatric assessment just as like this literally is the same. I think we panic because we're just like, oh, they're different, they're weird. Assessment is
Mm-mm.
not weird or different.
Right? It really is just...
Dosages are.
Yes, it's just understanding what their assessment is going to look like. You can't ask them how many quarters make $1 and who's the president.
Yeah.
You cannot ask them that. You have to just be like, are they screaming at me because they want their mom? Great. That's
Yes.
awesome. Or are they just like asleep in my arms immediately and do not care who I am? That's not awesome.
That is
That's
floppy
good.
heads. That'd be stressing me out.
I hate a floppy baby.
Why is it floppy?
Why you do
So
flop?
that's definitely high alert. Floppy babies, red flags
Red flags. Red flag.
all around. So how are we gonna discuss and communicate and document all that information, all those red flags?
Right, so a Handtevy doesn't just give you numbers. It trains you to commit to a physiologic story. So sepsis is a perfusion story.
100%.
And so there's going to be some recognition, and there's a practical EMS checklist.
Which would include mental status. So like we've already talked about, sleepy, difficult to arouse, not really interactive, or that, as Sophie so generously showed us, we cry.
It literally sounds like a baby sheep.
Yep.
Okay.
Yeah. So perfusion, so delayed cap refill, mottled skin, cool extremities, weak pulses. Work of breathing, so not just necessarily the rate, because babies have a very high respiratory rate, and sometimes it is difficult to get an accurate number. But you're looking for effort, fatigue, grunting, head bobbing, things like that.
And when you are trying to assess respiratory, drive, rate, work of breathing at all with kids, get them naked.
Yeah.
You can
need
weave
to
the
be able to see
diaper
all
on,
the things.
but you need to take off that onesie, take off that sleep sack, like whatever they're in needs to come off.
Yeah. They probably have a fever anyway.
Yep.
Mm-hmm.
And then we're looking at heart rate. So heart rate, like according to the patient's age, because there's a lot of variability there. So persistent tachycardia, even after the patient is calm, not screaming, crying, all of that, and after the fever is controlled, especially if that heart rate is consistently above what you were expecting, that should be an ominous sign for you. And
Not
then, of
great.
course, last but not least, fever. Or, even worse, hypothermia.
Yeah, that's just
Do not
that's
want
not good.
do not want a cold baby.
No.
Mm-mm. So how do you communicate this sepsis picture? Because it's not going to be as
Yeah, it's not gonna be like a grown up.
scientific as it would be with a grown-up maybe.
Yeah, there's not like explicit.
So you would use like quotes from the parents, like the story that they've communicated to you. So was normal yesterday, worse this morning, now they're lethargic.
Yeah.
So that shows a progression. You're going to document the trends that you've seen. So your initial cap refill versus after your fluid bolus, if you've had any improvement there, your mental status, with your interventions.
For sure. And trends are important in every single patient that we encounter. Like, that's how you assess people, is by trends, not just by one singular vital sign. But with kids, it's especially important because their conditions can vary and can change so quickly.
Mm-hmm.
And so you want to make sure that you're trending everything. What's working, what's not working, even down from like what parents have told you
For
already.
sure.
Trend from there too.
And their trend prior to seeing you.
Yep.
So speaking of treatment trends and condition, let's talk about our treatment priorities. So in pediatric septic shock, just like adults, time is very important. And the guidelines and the studies and all of it, they emphasize rapid recognition, early resuscitation, and early antibiotic administration.
Mm-hmm.
Okay? What's not something we often have on our ambulances, but it is so important. It is so important. I think that we have this idea in EMS or in emergency medicine in general that like quick interventions only matter when you're like going to die right this second.
Mm-hmm.
That is weird to me because there's lots of interventions that will stop you from dying later that we should be able to do.
Right. So like with kids, why does starting antibiotics as soon as possible within 1 hour of recognition, why is that important for EMS? Because like we don't even carry antibiotics. So like, man.
Why is that important?
Yeah.
Because we're the first to recognize it.
Right. And what about considering transport time?
Yeah, it could be, I mean, from your response to on scene to transport, there's a good chance that's an hour.
Right. And so you have to weigh, as like an EMS provider, you have to weigh, is it better for this kid for me to go X amount of time out of the way to go to a pediatric facility? Or is it better for me to maybe call our local facility and be like, I have this kid, they're septic, we need antibiotics.
Yes, I think
and
that
then we would like to go to our pediatric facility.
Yeah.
But it may be worth taking them to the local facility, initiating antibiotics, so long as you believe that that facility will do so. Initiating antibiotics, and then maybe moving on to a pediatric-centered facility. Because like transport time is a huge
especially to a
hurdle.
Pediatric facility.
Mm-hmm.
Like no one in most of this country is just right next door to a pediatric definitive care.
Right. And so it may be worth a more local option immediately to make sure this kid gets exactly what they need at the timeline they need it, and then can talk about a transfer later on. But do that responsibly.
Yeah.
Because you know your systems. You know what they're going to do, what they're not going to do.
Yes.
Like, you know.
You are allowed to use discretion. So, other than antibiotics, we have talked a little bit about fluid. Give your kid fluid. If nothing else, give them fluid. You are supposed to aggressively intervene in sepsis patients. And the thing is, I think it's because we look at adult patients and we don't, and we're getting better at it in our region especially, but like I feel like we don't assess for sepsis until they're already hypotensive. And if we carry that same thought process into pediatric patients,
we're never going to miss it, or never going to catch it.
We're never going to catch it.
It's going to be bad.
To give them fluids.
For sure.
To identify sepsis, call it out, report it to the hospital.
Right. And ask your parents, like, is there any chance of infection? Like, where are we?
Yeah.
And let me just tell you, with kids, there's almost always a chance of infection because they're gooey.
Yeah.
But, like, ask your parents, like, hey, have they been more sick recently? Like, do some digging. What about fluid choice? Like, what do you give kids?
What do you give sepsis patients?
Yeah.
Ooh.
Probably
LR.
Sorry, guys, by the way. LR is probably the most appropriate choice.
Yeah.
If you don't have it, that's okay, but you should. Can we give kids pressors?
Yes.
Yeah, guys. And if you don't have the protocol for it, call.
Medical direction.
Call for help. Because if you have a kid that's that sick, I don't know a single person who would be like, no. Don't give them
Absolutely.
pressor.
That's
Weird. That's a really weird behavior. I would recommend calling a pediatric facility. Like, if you're transporting, don't call your local facility.
Because they're going to be like panic.
Because guess what they're going to do when
Call
the
the
patient gets
pediatric
there? They're going
facility.
to call the pediatric facility.
Yes.
So.
For sure. And a good, like, phrase to remember is fluid refractory shock.
Mm-hmm.
Yeah.
That's the important aspect of we have given the appropriate fluid bolus and we are still in shock or we're still hypotensive.
Yes.
And now we would like to move on to this next step.
Yeah.
And just a little trick of the trade, a little tip. when you call medical direction, tell them what you want, not ask what you should do.
I need help. I don't know what to do. Tell me.
Yes.
They don't like that.
Say, this is what I would like to give. This is the dose that I would like to give it. Do you feel as though that is the appropriate intervention?
Yeah.
And that gives them confidence in you. If you call and you say, unless you like truly don't have a clue what to do, but if you call and you say, what do I do? A lot of times they don't feel confident in your ability to intervene, nor do they know what you actually probably carry. Like, it's just not a great way to call. So if you're calling medical direction, have a plan, tell them your plan, get that plan okayed by them.
Yes, 100%. No, like, have some kind of resource too. Like, we're not saying like you just need to know the vasopressor dose for a pediatric patient. It's okay to use resources, which is why we're talking about this today.
Absolutely. Sure. Let's talk about some high-risk pediatric sepsis calls that we actually see in EMS. So some pediatric patients are basically walking high-risk labels, and EMS should treat them like the margin for error is smaller, because it is. I actually love pediatric patients, and I love them because a lot of our supercritical patients that we see are geriatric. And you can throw intervention after intervention after intervention at them, and they may or may not respond. Yeah. That's not the case with kids. You get a sick kid, and you throw a couple interventions at them, and they can turn around, and it is crazy.
It's so satisfying.
It is so satisfying. It is crazy how much these kids can kind of curb.
Yeah.
However, since that is the case, if you miss the window of where your red flag should have been activated and you're teetering into uncharted territory where you now feel like it is appropriate to give these interventions.
Yeah, the pediatric Bermuda Triangle.
Correct. Then we have gone too far, my friend. So just remember, the margin for error is smaller with these patients, but just remember, they are still sick, and you can still do something about it.
For sure.
Like these patients. Let's talk about some high-risk groups within the pediatric community. So infants.
If a newborn has a fever,
Bad news
hospital.
bears.
Meningitis.
Hospital.
For sure. For sure, because why are we so concerned when newborns or very, very young infants have fevers?
Well, why do you have a fever, first of all?
Well,
You're
what
brand
the heck?
new.
You just got here, bro.
here.
What the heck?
Why do you have a fever? And
Same way.
we've already kind of touched on this, but it is so easy for these patients to get fluid down and to not be able to compensate.
Because they have like one syringe of fluid in their whole body.
Literally.
Right. Like, and these kids, like when you were born with innate immunity. It is all you're born with. And so it's the immunities that you get from your mom. And innate immunity is not very good. They're basically like, they walk up to the virus and they're like, yo, bro, could you
get
stop?
Get out of here.
Thanks a lot, Mom.
And the virus is like, no. And they're like, all right, well, I'm going to call my friends. And then their friends are also all teeny tiny small. And they're like, how about now? And the virus is like, I'm still not scared of you.
Yeah.
And that is what these kids have. And so they have not yet built their adaptive immunity. They've not built the immunity that comes with exposures to illnesses and things like that. And so there's a certain age where like it is not safe for them to get sick at all.
It is just as concerning if you're a cancer patient or you're a transplant patient or you're immunosuppressed in any other way patient gets a fever. They go to the hospital, right?
100%.
Your infant does too. Newborn does too.
Yes. Now, what happens when you have a immunocompromised kid?
So they used to have an immune system.
No,
now
they don't.
their immune system no longer has the fighting capacity. So it is the same as an itty bitty baby newborn, no matter what age you are. 0 to 100. If you are immunocompromised on chemotherapy, on immunologic medication that could suppress your immune system, transplants of any kind, high steroid patients, this one kind of gets missed. So kids with like juvenile RA, maybe they have some respiratory issues. If they have high dose steroids on board, that can suppress your immune system as well. And parents usually know these things.
Yeah.
What about medically complex kids? So kids that have like a VP shunt or a trach or a G-tube.
If you have anything that is there that's not supposed to be there, automatically assume the worst case scenario that it is sepsis.
Yeah.
Yep, because you have an entry portal for infection.
Yes.
Yep.
And with all of these devices, defer to parents. They will know what looks normal. They will know what does not look
Yeah.
normal. Odds are they will be like, I think their G-tube's infected because their site is red
Yeah,
and
look at
it's
this thing.
oozing.
Yeah.
And yeah.
Yeah.
Like a lot of times they already know, but if there is a device in place,
If they have a VP shunt and they're acting funny and they have a fever,
run,
run.
run.
Yikes.
And then obviously the normal things like any hospitalization, surgery,
Oh yeah.
that kind of stuff. That
Especially,
just makes
like,
sense.
They've been throwing up for a few days. I took them to the hospital yesterday. They said they were fine. Now they're lethargic and they're hard to wake up.
Yeah, 100%. If you have a patient with a neutropenic fever, do you guys know what a neutropenic fever is, audience?
Explícame.
Neutropenia is a condition that results from low neutrophils, low white count. So a neutropenic fever is very common in patients who are immunosuppressed, especially cancer kids.
Mm-hmm.
So they're instructed to go to the hospital when they
Yes.
have a fever.
So you've got a kiddo with cancer that is immunosuppressed, fever of 101.9, called their doctor, told them to call 911. What are the EMS's priorities?
This is sepsis until proven otherwise.
Yeah, 100%.
Automatically.
For sure. It's time sensitive because remember, this kid has no immune system. So whatever is in there can wreak havoc until there is an external force that tells it to stop.
Yes.
So getting a kid to a place where they can give that external force to tell whatever is wreaking havoc inside their body to stop is very important.
It's likely that they already have some kind of line, which
Mhm.
could be the source of infection.
For sure. So you want to be really careful with accessing whatever that line is because that could be our problem.
I would recommend not,
Yep. Don't do that.
but if that's all you got, it's all you got.
Try to establish something else. And then appropriate facilities. So let's talk about that. Where are the parents going to want to go?
Where that kid is receiving treatment.
Which is the most appropriate choice.
Yes.
If you can get that kid to where they're receiving treatment, that is where they should go, hands down.
110%. I
Mhm.
cannot stress this enough.
If you feel like they're too critical to make it that far, have that discussion with the parents. Come
If
up
you're
with a plan.
that far away, that time in transport is going to be a problem, and you can call an aircraft.
Yeah.
Okay, so real situation number 4. So you have an infant.
This is a call, man.
Mhm.
That gets swept under the rug.
Oh, yeah. Have an infant with poor feeding and hypothermia. So the scary truth is that not all sick infants have fevers. Hypothermia can be a huge red flag. Any infant that is feeding poorly, because mom is going to know why. So any infant that's feeding poorly that they have called you because they're like, I don't know why this is happening. The duration of the poor feeding is very important.
Mm-hmm.
How many ounces they've been able to actually get is important. And is this an issue where like babies had a hard time latching for the duration of breastfeeding?
Yeah, it's been a struggle.
Maybe we're transitioning to bottle and it's not going well. Like there are other reasons, but make sure that you identify those if they exist.
And they probably still need to go
Yes.
be seen at a
Because it still
facility.
matters. If we've been
Yeah.
feeding poorly for 3-4 days, we are in a way.
Yes.
Yeah.
And I can't tell you how many doctor's appointments like I've gone to, like I haven't gone to the doctor, but like responded to for hypothermic infants.
Yeah.
They just automatically, because that's a problem. These kids are bundled up 24/7. Why
Yeah.
are they cold?
Why are they
Yeah.
That's
cold?
bad.
Why are they cold? They're
Don't
in 17 footsie pajamas.
yes. Don't say call the doctor. Don't make those recommendations. That's all I gotta say.
Yeah. Mm-mm.
Um,
So, moving on to documentation and handoff. So how EMS triggers the hospital's sepsis machine. So your documentation can be the reason the hospital takes this seriously or the reason they don't. Sepsis pathways depend on the story, the timeline, and the perfusion picture. And just like we get to a scene and we get information about the patient from parents, and we really only know as much as the parents can tell us, a lot of times the hospitals are in similar situations.
code sepsis.
Yes, they really only know what it is that we tell them. Now they can investigate later on, but we want this to be expedited as quickly as we can.
Mhm.
So if you are suspicious of sepsis, or you have enough vital signs and documentation that you're like, this is sepsis,
Yeah.
absolutely call it. Go ahead and activate that
Yeah.
process so that they're prepared for you. And if the doctor wants to downgrade that and be like, I don't think they're septic,
That's fine.
that's totally fine. But it's not going to be, you're not going to delay this kid's care for overactivating.
Right.
But you can delay it by not activating.
Yeah.
I agree more. It's way, and anytime I've had a new, like a medic student or a new hire that's new to, like, being a paramedic, I'm like, if it crosses your mind and you're concerned, like truly concerned, not like, oh, I'm thinking about a differential, you're like, oh no, this could be this, and it won't leave your mind, just err on the side of caution. Like, same thing with, like, weird strokes.
Yeah.
You'd be like, yeah, this is weird. I need to call this. Then call it.
Yep. There's been plenty of times that we have had just weird neuro where they technically don't hit the criteria, but like the juju vibes are off.
And that's what we talk about, right? Intuition, we talk about our sixth sense. It's pattern recognition, right? Like, and that's what Handtevy is all about, is like, our job is pattern recognition. So if you feel those vibes, that's your pattern recognition kicking in and saying, hey, pay attention.
Yeah. Faux show.
So along those lines, what should we document? So we want to document the timeline of their illness, onset, worsening, the last time they were normal, how long this goes on in kids. A lot of times is a great indication of what is going on with this kid. Your perfusion exam. So kind of what OBS has already gone through. Cap refill, skin signs, pulses, temps, your mental status, response to interventions, and the direct quotes from the parents.
Yeah, it's okay to do that.
Yeah, this is not my child's normal behavior.
They are acting strange.
Yeah, write that down as a direct quote. And remember to document the kid's response to every intervention you do. And so there is a, like we had a conversation about documentation where OBS points out that we are not very good at documenting like how people respond to our interventions.
Yes,
we're like, I did
or
this.
why we didn't do an intervention. Yes.
We're like, I did this, this, and this at hospital. Goodbye.
Yes, it's weird. Why did we do that?
And then I'm like, well, what happened to them? And so with
hopefully it was fine.
Don't get to know.
They put better on arrival.
With kiddos, it is very good to use their response to your intervention to help like justify why it is that you did what you did.
Yeah.
Because you will see a response to your interventions.
For sure. Or why you stopped doing what you were doing. Maybe it got worse.
So now that we have established how we're going to document, now that we've intervened, how might you call over to the hospital to kind of let them know the skinny of what's going on?
Yeah, so you could say something like, I am concerned for sepsis. We have poor perfusion. We have a cap refill of 5 seconds. We have modeling present. This patient is tachycardic, and they have had decreased interaction with me throughout transport. This patient has received 20 mLs per kg of fluid. Their cap refill improved to 3 seconds, but they still are tachycardic. I'm concerned for septic shock due to these findings.
Love it.
Perfect.
And that's it, guys.
Whoop.
Children need the same intervention as adults when it comes to a lot of things, most things, especially sepsis. We can't wait until it's too late. Pediatric sepsis is a stealth emergency. They compensate, families minimize, and the scene looks calm right up until it's not.
And the data backs up why we take this seriously. Tens of thousands hospitalized, thousands of pediatric deaths, and outcomes tied to early recognition and early treatment.
EMS isn't expected to diagnose the organism. We're expected to recognize the physiology, perfusion failing, mental status changing, shock developing, and to document it in a way that triggers life-saving urgency.
Tiny humans, big humans, you're all the same. Goodbye, and we'll catch ya on the next one.
This has been Life in Sirens, produced by 3 nerds trying to bring you content that you might actually care about.